Hello everyone, it's Schematic Med, and today we're going to talk about pathophysiology of massive pulmonary embolism. Patients with massive pulmonary embolism usually present with pleuritic chest pain, signs of low arterial perfusion, for example hypertension and syncope, acute dyspnea and tachycardia. The thrombus increases pulmonary vascular resistance and right ventricular pressure, which will cause right ventricular hypokinesis and dilation and hypotension. You can see here I drew schematically the heart, and we can see right ventricle and left ventricle, and we can see the thrombus. So this thrombus will increase right ventricular pressure. That will cause decreased hypokinesis of the right ventricle and the right ventricular dilation. Right ventricular hypokinesis will decrease the right ventricular outflow, and we know if the right ventricular is giving less blood to the left ventricle, it means that left ventricular preload is decreased. If left ventricle receives less blood, obviously it will give to the tissues less blood too. So that is what we call cardiac output. So the cardiac output will be decreased and blood pressure will be decreased too. Obviously, if left ventricle is giving less blood to the tissues and one of the tissue is right ventricle too, and a right ventricular oxygen supply will be decreased too. Right ventricular dilation will increase the right ventricular wall tension, and if the tension is increased, obviously right ventricular oxygen demand will be increased too. So when the demand is increased and the right ventricular oxygen supply is low, we will eventually have right ventricular ischemia and infarction, which can lead to right ventricular failure and shock. Thank you, bye.